Morning, everyone. At the outset, thank you for the opportunity to present at the AIOC midterm. Uh, Today, I would be speaking on safety-enhanced tarsofrontalis sling surgery in cases of complex ptosis. Safety-enhanced tarsofrontalis sling surgery is considered only in cases of severe ptosis, where we are dealing with two primary things. One is an ocular motility restriction, and two, a poor Bell's phenomena. In our assessment, the mean age at presentation was 32 plus 20.8 years, with the interquartile range of and the range of 5 months to 69 years. Of the study population, we had 68% were males and 32% were females. 25 patients and 39 eyes were analyzed. The clinical spectrum of the complex ptosis we had where first is chronic progressive external ophthalmoplegia, where 36% of the cases were of this subset, where apart from a severe ptosis and ocular motility restriction, we are also dealing with a progressive weakening of the orbicularis oculi muscle. Second, congenital causes along with monocular elevation deficiency, and those ptosis with poor Bell's phenomena, which constituted 20% of our cases. 8% were blepharophimosis syndrome cases, and 20% accounted from trauma and other causes like third cranial nerve palsy. The methodology involved a retrospective interventional case series where the study duration was 2014 to 2022, and 39 eyes underwent the surgery, where we assessed for the severity of ptosis, and we used a 800 micron silicone sling. The idea of using silicone sling as a suspension material, because it allows a complete closure of the lid against its inherent property of elasticity, the ease of adjustment if needed at a later date, and because it remains non-integrated with the surrounding tissues, the sleeve can be easily lifted off from the depth of the incision. The technique we followed was a Fox suspension method, and the outcomes were two primary ones, which included: one is the change in the amount of ptosis, and second, in terms of the ocular surface integrity, analyzing the exposure of the corneal surface. The analysis involved mean follow-up was 12.9 months, and all patients had clearance of visual axis with a mean change in the MRD1 of 2.9 mm, and exposure keratopathy and recurrence were noted in 4% of our cases. So this is a patient where we can see a clearance of the visual axis. The idea in a case of a safety-enhanced tarsofrontalis sling surgery is a willful or a voluntary undercorrection, such that we are not exposing the corneal surface. And second is to do an extreme lateral tarsorrhaphy, which would decrease the incidence of exposure keratopathy. This is again a case pre and post-operative 6 months where the visual axis is clear and ocular surface integrity was maintained. It also allows for a maintenance of an aesthetic outcome to our surgery, where a desired lid height and a symmetrical position of the lids as ocular plastic surgeons also becomes a pivot to our surgery. And no patient in our series actually required a sling removal. And safety-enhanced TFS surgery is preferred in complex ptosis because of these reasons. It clears the visual axis, which is important. It gives a good functional and aesthetic outcome and minimizes the risk of an exposure keratopathy. These are my references. Thank you.
You have mentioned the term safety enhanced. What
Yes.
do you mean by that?
Ma'am, safety enhanced because in the subset of cases, for example, chronic progressive external ophthalmoplegia, where we are dealing with a progressive weakening of the orbicularis oculi muscle and also ocular motility restriction, we undercorrect the ptosis such that we are just clearing the visual axis, one. Second, we do an extreme lateral tarsorrhaphy, where we are maintaining the tarsorrhaphy in place for a minimum of 3 weeks and following these patients up on a daily basis, such that we are decreasing the risk for exposure keratopathy, hence a safety enhanced.
Very nice presentation. You had 4% of exposure keratopathy,
Yes,
right? So actually the main cause of this exposure keratopathy is basically the leg ophthalmos. So these patients, what they happen when you use a sling, which leads to a very static lift of the upper lid.
Yes.
So now what we advocate basically for all CPOs or the myasthenia, it is a frontalis flap advancement. Why we do this gives a very adequate correction. Number one, you do not get leg ophthalmos. So many papers, so many reports have come up that all cases of myasthenia or cases of CPO or very severe ptosis, this is a better option because you don't get leg ophthalmos. And that is what we want, to give the safety. We don't want leg ophthalmos, we don't want the eye to open at night, which leads to exposure keratopathy. Anyways, it's a good documentation, but you should consider this technique also, because this is the only technique where we don't say leg ophthalmos following the surgery.
Sure, ma'am.
Okay.
Will do, ma'am. Thank you.
How long you are supposed to follow up these cases?
Ma'am, since these are cases of complex ptosis where we know that the ocular surface might get compromised and there is a poor Bell's with restricted motility, we follow them up on a daily basis.
No, in initial post-operative period, what is your follow-up schedule? And in late post-operative
In
period?
initial post-op period, ma'am, it is daily basis, ma'am. We follow them.
Cases were admitted?
No, ma'am.
Also.
We do not admit, ma'am. They do come for a follow-up to our hospital. Yes.
Excellent presentation,
Thank you,
SUBHAV, and very good slides. Can I have the last slide of yours? Dr. Ka presentation, yeah.
This one, ma'am.
Yeah, so what is the safety enhancement in this?
This was post-op, like 1 year post.
No, I mean, just a discussion, right? Yeah,
Yes,
so
ma'am.
probably you picked up a wrong image,
Yeah, maybe. Yeah.
right? Yeah, so
Yeah.
you have to be very careful when you're presenting, when you're talking and, bringing up a message,
Yes,
right? So this doesn't look safety enhanced, right? Yeah.
ma'am. We'll
Now,
take care.
a second question that I have for you is when we talk about monoocular elevation deficiency, MED, do you take your squint specialist opinion?
Yes, ma'am,
before that?
definitely.
Yeah.
Because the basic idea is the lid follows the globe. And in cases of monocular elevation deficiency, the idea is to correct the hypotropia first under the guidance of a squint specialist and then reassess ptosis, following which the need for surgery can be determined.
All right, yeah. Good. Yeah, so that is so very important, right? Yeah, so it is kind of a teamwork between the squint specialist and oculoplasty. And first they go to the squint and then
Yes,
they
ma'am.
come to the oculoplasty. Now, in your case series, was there any case where you had to actually bring it down because of the exposure post-surgery, or everyone did perfect?
Ma'am, one case we had exposure keratopathy,
And
ma'am.
what did you do for that?
Ma'am, it was managed medically.
Medically,
Yes,
you didn't
ma'am.
bring down.
We didn't have
the
to revise the surgery per se, ma'am.
Okay, okay, that was a question. So sometimes, a sling, as ma'am said, it's an excellent technique, but when we use a silicone sling, if at all there is a corneal exposure keratopathy, it's always easy to, undercorrect. You just have to go there and loosen it up. So that is one of the advantages
Of
we
using
have.
a silicone sling,
yeah.
ma'am.
Thank you.
Yes, thank you, ma'am.
The message I wanted to ask, the message is definitely that for vertical squints, the squint should always be operated, taken up first. What was the sling material that you used?
Ma'am, 800 microns silicone
Okay,
sling,
yeah.
ma'am. We prefer to use BD Visitec, but we also have a second option of Oro
Oro
sling too.
sling. So did you find any, compare between Visitec and Oro sling, did you find the complications which are often said they are more in Oro sling, the granuloma
Ma'am,
formation? or
one thing definitely which we can put across is the tightness of the sleeve. The diameter of the sleeve is a bit narrow in Oro sling, ma'am, as compared to the BD Visitec, ma'am.
And while you did this study,
Yes,
did
ma'am.
you check the incidence of Bell's phenomena? You didn't mention. What did you find? How many patients had a poor Bell's phenomena or fair, or did you try
Ma'am,
to
in
find that out?
all these cases, 39 eyes had a poor Bell's phenomenon.
Poor Bell's phenomena.
Yes, ma'am.
So under correction, we already know that we do when we have a poor Bell's phenomena. And yes, this tarsography you have added. Were you doing this tarsography in all the cases?
Yes, ma'am. Yes, ma'am. That
All
is
cases you
yes.
did a lateral tarsography in a
extreme
routine.
lateral tarsography. Yes.
And a Fox pentagon was your first choice, or did you think of trying the double triangle also at any time?
No, ma'am. We performed it was performed by a single surgeon, and Fox pentagon was our method of choice.
Okay. Thank you.
Thank you.
Thank you.